Hi, everybody. Welcome back to my LinkedIn Lives. I'm Jasmine Navarro, certified wellbeing expert, working in educational institutions and companies, helping them support their wellbeing challenges. And as you know, every week I interview different experts who make a difference in people's lives. And today I'm super excited to be interviewing Carrie. Carrie, hi. Thank you so much for coming on.
Hi there. Thank you for having me. I'm so grateful to be here.
Can you tell us about yourself and what you do?
Sure. I'm a mental health therapist, and I also am the owner of a small private practice called Inside Out Counseling. And I specialize in treating OCD and anxiety disorders. And I work with a pretty specific modality, therapy intervention, which is cognitive behavioral therapy, and then the therapies that fall under that umbrella: exposure therapy, acceptance and commitment therapy. I work with adolescents and adults. A lot of my clients are college students, and I also work with perinatal, so pregnant women, postpartum women as well, and other adults.
Wow, that sounds really, really interesting. So you chose this title, The Real Side of OCD, Obsessive Compulsive Disorder.
Right.
Can you tell us, what made you choose this title and what does it mean?
Yes, absolutely. So I chose this title because well, first of all, we all kind of have, I would imagine, an image of what OCD is,
Yes.
in our mind. Obsessive compulsive disorder. We see it presented in movies, and what comes to mind? Maybe contamination, right? Somebody is in the movies and they're cleaning, or
Yes.
they're, not stepping on a crack. So we have this image. And then
Yeah.
we also see it portrayed in the media and social media. Maybe somebody's taking a picture, I'm so OCD, and they have this beautiful cupboard in the background or closet. And in reality, some of this, if somebody's saying, first of all, they're so OCD, most likely they don't have OCD. And I'll talk about that why
Yeah. Yeah.
that later. But how it's portrayed in the movie, sure, there is contamination OCD, but there are lots of other types of subtypes. And there's, probably about 12 that are pretty common, 12 to 15 subtypes.
Wow.
It's the more taboo subtypes like harm OCD that we don't hear about. And so, I chose this topic because I really want to increase awareness on how OCD truly does present. And the reason for that is because even our providers, other therapists, doctors, midwives, OBGYNs, they don't entirely not, I mean, lots of course do know, but others don't really know about those taboo subtypes as much. And also, really, we know that individuals with OCD, they do not seek help for up to 17 years, more than a
No
decade.
way.
So they suffer silently. And one, they may not know what they have, they may be fearful. Or I often have clients that come to me who've been in therapy and have not been diagnosed, and they've been treated um, for something else that is only maintaining the OCD. So it's to increase awareness.
Wow, that's
Mhm.
heartbreaking, actually. 17 years. Imagine
Yes,
you.
before on average, before they'll seek treatment for their OCD. And it's also, I got to mention, this is the other shocking part, is it is one of the most debilitating mental health disorders.
Wow. Oh my God.
Mhm.
Wow.
Yes.
Okay. No, I'm so glad that you're here today to talk about this. I'm sure I'm going to learn a lot as well. So can
Great.
you tell us because like you said, so many people do say, oh, I've got OCD. I'm a little OCD. You hear it.
Yeah,
People,
yeah, it's
okay.
common, right.
What is OCD and tell us, please.
Yeah, sure. So OCD, we have obsessions. So the O,
Right.
and obsessions are going to be, they can be a thought, an image. Some people really, have these vivid images. There can be a sensation, and it can be an urge. And this obsession gets stuck on replay. And this obsession causes the individual significant distress. It could be anxiety. It could be disgust, even. It could
Really?
be
So the
shame.
feeling. It's a feeling then.
Yep. So
Okay.
if you think about a thought, thoughts are actually responsible for our
Yes.
emotions,
Yes.
right?
Yes.
So
Yes.
if you have, like, for example, if somebody's driving down the street and they have this urge or even see themselves driving off and hitting a tree, this would be
Okay.
an obsession. Now, well, it turns into an obsession if it gets stuck on replay.
Okay.
Because
Okay.
we're all going to have a harm thought. 80%
Yes.
or more will have a harm thought in our lives. The only difference between somebody with OCD and without OCD is that the person without OCD will say, oh, that was really weird. That was scary. Whoa, I can't believe I had that. And they
Yeah.
move on with their day. Now, if somebody has OCD, that's going to get stuck on replay. So they have then the emotion, and then they start to engage in compulsions. That's the obsessions and compulsions.
Oh,
The compulsion would be something to get rid of that obsession and the negative emotion that comes with it. So maybe I'm driving down the street, this image just keeps coming back every time I drive. Maybe I start saying a prayer or singing a song or counting. That would be a mental compulsion. Or I might avoid. Maybe I stop driving now because I don't trust that
yeah.
I'm not going to do that.
That must be terrifying as well, because
Absolutely.
it's replay. So you have the thoughts,
Mm-hmm.
but then the thought comes back and again and again and again. Like, how many times do you have that?
Yeah. I mean, and here's the thing. So this can take up to hours. So now we look at the individual as having, and the thought is not the problem. So this is what
Okay.
we want to really like clarify. The thought's not the problem. We look at this, how are you reacting to the thought? So what happens is individuals, we're humans. We want to avoid anything that doesn't feel good. Our brains are beautiful. They're set up to avoid threats. This is what has kept us alive, right? If
Yeah.
we go back to
Yeah.
hunters and gatherers. So individuals, what they start to do, those compulsions, that actually is going to feed that cycle. And the compulsions can take up to hours a day. I mean, so somebody's trying to leave their house, and if they have symmetrical OCD, everything has to be just aligned, or just right OCD. They can't leave until everything feels just perfect. Now they're in this cycle. This is called the OCD cycle of the compulsions, and that's what really starts to be consuming. And the more compulsions you do, then the more obsessions. So there's this phrase that I'd like to say: what we resist persists. So we're trying to push it away, avoid it, not think about it, get rid of that feeling, and that's what's maintaining that cycle. It's called the OCD cycle.
Wow. Say hi to Angela. Hi, Angela. Thank you for joining us. Angela says, wow, I didn't realize some of my coping behaviors could be seen as compulsions.
Mm-hmm. Absolutely. And that's coping behavior. We also call these safety behaviors as well. And when it starts to interfere with your life, that's when because we all have compulsions, we all have safety behaviors, right?
Okay.
If you start to see this cycle and this pattern, and what happens with those compulsions is they might work initially, but then they stop working. So we need to do more and more of those.
So how do we know when it's like a normal sort of, what you said about replay is on repeat? Like, how do we know when we need to maybe ask for help or something?
Yeah, that's a good question. That's a great question. It's really, how is it affecting your life? Is it affecting your quality of life? My clients come to me and I often hear, I just want to enjoy life. I just want to be present.
Yeah.
So I think, it's the person, and it's what's happening with them. And that's what happens is they stop being able to find joy in their life because they're so consumed. And what comes, as I mentioned, these negative, uncomfortable, I don't want to say negative, because anxiety is not a negative emotion. It is a really important. We need anxiety. We never want to get rid of it. But when you're in this hours of anxiety, extreme anxiety and distress, this is a problem. Mm-hmm.
Exactly.
It doesn't have to be hours either. It could be an hour a day. It's up to the person of how much it's impacting them.
No, it sounds absolutely unbearable, actually. Because like you said, I don't know if you could talk us through some of the obsessive compulsive disorders that people you've worked with. Like, I know you can't say any names or anything, but
sure, absolutely.
Yeah.
Well, I definitely work with harm OCD, perinatal. I've had perinatal OCD, so that might present Again, perinatals for us, we use the period of while you're pregnancy and then up to a year after delivery. So this is a perinatal. This is important to know that 90% of women during this perinatal period are going to have intrusive, unwanted, distressing thoughts.
Oh, really?
And up to 80% of dads. So we see that with, one reason they're not quite sure, but with perinatal probably has to do with this chemical imbalance. And so I work with perinatal. So, somebody might be worried that something's going to happen to them. Okay, so for example, you're a new mom. What's the worst thing that could happen? What do you value the most? This is where OCD attacks. I need to be here for my child. What would their life be without a mom? So now they might go and start checking their baby. Are they breathing? We all do that, right? If you've had kids, you've done that. You're checking, you're peeking. But now, are you not sleeping? Are you checking 20 times a night? And I always say we follow what the doctor says. So this is if it's hard to kind of distinguish. So that would be one. That's a compulsion because there's the fear of something happening to the baby dying. It could be a fear of dropping the baby. So this is perinatal. Or maybe you feel like something's wrong with your health. So it's constantly checking your own pulse or yeah. So that, but other subtypes, I mean, so I mentioned the harm subtype, that you fear you're going to harm yourself or somebody else. And that could be even like, what if I you give my baby food or milk, maybe it's not breast milk, and formula, and there's something wrong with it. So there's checking, they're smelling, they're remaking it. And this becomes a fear. What if I give them something and they get harmed?
Do they keep checking?
Yeah, well, that's
do they give the thing eventually, or do they, because you can just be frozen, can't you, in that, like you said, repeat and
exactly. Well, another compulsion would be now the mom stops doing it and has somebody else check, somebody else give the food. So that could be a safety behavior. But other subtypes I jotted down. So we have religious, contamination, health, just right. Meta is anxiety, about having anxiety, emotional contamination, somatic. So there are all these different types of, and I treat all, I have clients with all different types, and they present, differently.
Yeah. Can you tell us a little bit about them?
About each of those?
Yeah.
Well, let's see. So health, and some of these too. So for example, there is illness anxiety. There's a separate diagnosis for illness anxiety. But then there's also the subtype. So one, we have to kind of distinguish, those two present very, very similar. So this could be a fear of getting a serious illness. So maybe they're worried that they have cancer. It's like, I notice a mark or a spot. Then we start to engage in compulsions, checking, Googling, doctor's appointments. That could be how that presents. Yeah. And so they're all, just right. That would be, I kind of mentioned that would be where somebody, things just feel off. So it's almost like this really uncomfortable feeling in your body. And then it becomes organizing and trying to get everything a certain way to eliminate that feeling that they're experiencing. And harm, I mean, I'd mentioned harm. That could be like having an image, of driving off the street into a tree. It could be an image or an urge. Here's an example of an urge. You're on an escalator and you have this urge to push somebody, or a thought, which feels like an urge.
Okay.
And so this is what I think is really important to mention, is that somebody who does have, let's say, harm subtype, this is would be considered more, I say, a taboo. It's less talked about, is that we know they're not going to do that. Individuals with OCD never, ever, ever act out on their obsessions. And how do we distinguish somebody with OCD from maybe somebody who has psychosis or a psychopath? Right? Because it's like what people often ask. Well, what we know is individuals with OCD are ego dystonic. So ego dystonic means that, you know, what they're feeling or thinking in this situation with OCD, their obsession goes entirely against their beliefs and their values. And that's why
Wow.
it's causing the distress. So it's OCD if we have an obsession, gets stuck on replay, and it causes us just significant distress. And what we know about OCD is, I mentioned earlier, it attacks those things that we value the most. Maybe that's your health. If you're a mother, I need to be there for my child, or it's your child, or it's your relationships, family. So this is where we really look at what do you value, and we can pretty much see that's OCD
Wow.
attacks that,
Wow.
which
That's really
why,
interesting.
yeah, it increases those emotions. So it's just
Sounds absolutely awful.
uncomfortable.
Like, where do you know? Do we know where it stems from? Like, how, where
Yeah.
would it come from?
Yeah, well, you like science and other mental health conditions, other mental health illnesses. We're not exactly with 100%
No.
certainty. And we will say we've got some, some things that we see, some commonalities, really strong commonalities. And the first one is genetic.
Okay.
So yeah, I mean, I don't, maybe I have, it's very few clients that I will have or have had that we cannot place to somebody else in the family.
Oh, really?
Yeah, and a lot of times, I mean, maybe they don't have a diagnosis. Our grandparents, were they going to therapy? Probably not. Our parents even, probably not. And it depends on
Yeah.
cultural. Like there's so many, what does therapy look like for that individual? But they'll once they start to learn about OCD and what's going on, it's like, oh yeah,
I
mom did
recognize.
the same thing, or grandma or grandpa. So genetic is one. The other is that there's we see or believe that there is a serotonin imbalance. And that's a chemical that's really crucial for functioning. So when that's, off balance, that's where some of these things are going to, get stuck and be intensified. And then also oversensitivity to anxiety symptoms. They feel, let's just say, more intense, more uncomfortable than somebody else who might experience that anxiety. I say multiply it by 10 or 100, so if you have a,
Yes.
anxiety. So those are the things that we see. Yeah. Mhm.
Wow. And you mentioned before, I don't know if I understood this correctly, because you said
Mhm.
about having the thoughts and then the compulsion, and then you go back to the thought. So does it kind of, so it's like a circle?
Cycle. Yeah. Yes. So the OCD cycle is obsession, anxiety, distress, compulsion, relief, and then it starts all over. So and we know that's why we know we got to get rid of the compulsions. That's part of the therapy because it feeds. So that relief, it works initially, it stops working, works less. Now we need more compulsions. We need to keep doing so.
Yes,
That's the
exactly.
cycle: obsession, anxiety, compulsion, relief, repeat.
So interesting. Let's just see what Angela says. Angela says, absolutely. In my case, I've noticed my cortisol levels are getting to the roof as these behaviors do not allow me to enjoy certain things in life.
Hmm. Yeah. Thank you for sharing that.
Yeah.
Absolutely. Yeah.
Thank you, Angela.
Yeah.
And she does Angela has a question. How do you determine if these behaviors are related to autism or OCD? I don't know if
Hmm.
you would know that, Carrie.
Yeah, yeah, another excellent question. Well, we know that actually individuals, we see higher rates of OCD in individuals with autism. So really how do we determine it? It's going to be through a diagnosis and a full assessment to come up with a diagnosis. And there's different so if you have autism, then we want to diagnose if there is an addition. And you absolutely, like I mentioned, we have those two go hand in hand quite often. It would be through a full assessment with a mental health specialist that will diagnose the OCD. Now, autism general therapist like myself, I'm not trained or allowed to diagnose autism, so that would be a neurologist that would do that diagnosis. um,
Wow. No. Yeah.
yeah, but I don't know if that's like, but if they're related, how do we determine if they're related? We just know that there is a higher number of OCD with individuals who have autism. There's some
Wow. Wow.
correlation, but not again, why is that? Not quite sure. 100%.
Yeah. No, thanks, Angela. Thanks, Carrie. Really, really interesting. So I know you've got so much experience in this field. So how do you help your clients with this? Like, what's the process?
Right. This is my favorite part. We don't want people to suffer. We want individuals to enjoy their lives. And this is really how I got into what I do, is because of the therapy, because of the modality. I love the therapy I work with. And why do I love it so much? Because it works and we receive relief and we see these symptoms. With me, my goal is to bring those symptoms down.
Yes.
And so the therapy is called, for OCD, there is a gold standard mental health therapy, and that's called exposure and response prevention therapy. And so
Okay.
there's really two parts to that. We have the exposure. And so the exposure part is very strategically, intentionally facing the things we fear. And
Oh,
while we do that, we do the response prevention, which is not engaging in compulsions and safety behaviors. So we can't do an exposure, like if, maybe somebody has one of the subtypes I didn't mention of, and it's also a phobia as well, is a metaphobia. It's a fear of throwing up. So if somebody has OCD, or it's treated the same way actually. So regardless, so what we might do for an exposure would be to show them pictures of throw up, puke. That's an exposure. That's called an
okay.
ego exposure. Yeah. Then we might make fake throw up. Then we might make like soup and oatmeal and make things.
Really?
That's an
Oh,
exposure.
wow.
Then maybe we take it up a level and put it in our mouths and throw it up, fake throw it up, not real throw up, in the toilet.
So you
We
do that in the session? That all happens in the session?
Yes, actually, yeah. And I'm virtual, mostly virtual. I will go out in the community if someone needs extra exposure assistance with exposures, but it's beautiful because I can come into people's homes virtually, and we'll do that together. Yeah. And we might listen to recordings of people throwing up. This is an exposure.
Oh,
And now
wow.
we can't do that compulsion at the same time, which might be another compulsion, is self-assurance. Oh, you'll be fine. You'll be fine. You won't throw up. You're not going to get sick. We cannot do that during the exposure. And we eliminate those entirely as well. Like eventually those become bans and they come out of the picture.
Wow. So that exposure therapy, you do that with any type of OCD. So
And
like
that's the gold standard. That's the therapy
really,
that's used to treat
really?
OCD and to work. At one
Wow.
point, OCD was thought to be untreatable. About 50 years ago, they didn't really know there was a treatment for OCD, and this
Wow. So
beautiful therapy was discovered.
how would you so you mentioned the just right type.
Mhm.
How would you expose that one? You'd make them feel uncomfortable.
Oh yeah, we go mess up their whole table or their desk, and then they have to leave it there. And so here's the thing: so we'll do an exposure and say, okay, let's just go, and I'll do it with them. I mean, I never ask my clients to do anything I won't do. So I do a lot of. This is why I'm doing this podcast. Was I scared?
Yeah.
Was I anxious about it? Yes. And I'm like, well, I ask my clients to do hard things every single day. I'm doing
Wow.
a hard thing, and I question, what's coming up? Oh, I could just avoid it and not do it. And then the anxiety goes away. It's like, no, you're going to be avoiding because of fear. So for example, like my picture back here, this is Ferdinand,
Yeah.
but I might, for somebody who has symmetrical OCD, I'll turn that picture sideways, and then they'll come into session. I'll be like, hi, how's it going? They're like, hi. And they're like, and somebody might not be bothered by that. One client with the OCD and another might really be bothered by that. But
And then what happens? What happens then? So they're feeling like, no,
yeah,
I don't like this. And then what do you do?
yeah, that's a great question. So how therapy would look then with me and with other specialists in ERP is, I would say, well, what's coming up? What's OCD
Okay.
saying right now? Because, just like somebody's not cancer, somebody who has OCD, they're not OCD.
Yes,
So a
yes,
big
yes.
part of my therapy is we're separating them. What's OCD saying? And we do different activities early on. There's lots of psychoeducation early on. But so let's say, with this is, they might say, well, they're saying that I want to ask you to put that back. Like I want to ask you, okay,
Okay.
so what are you going to say to OCD? I see you, OCD. We're going to label it, not listening to you. Because often OCD is asking for you to do something, which is that compulsion or safety behavior. I want to straighten that. So we sit with it. And then what we do is we intentionally bring anxiety up, and then we wait until anxiety
Wow.
comes down. And this is where the learning takes place. So why do we do this? Is because we're teaching our clients to get comfortable with the uncomfortable. And it's such
Amazing.
a powerful feeling when you bring that anxiety on and you feel it come down. This is
Yeah.
amazing. And then also we look at, what do you fear is going to happen? If you look, for example, back to the harm, the driving the car. Well, I fear I'm going to drive my car into the tree and die. Okay, well, let's see if that happens. Go drive. Now we're going to drive. That'd be an exposure they do on their own, or I'd have to meet them in person. And then we look at fear anticipation. How much do you believe that's going to happen? Ooh,
Oh,
80%.
yes.
Okay, let's drive. What happened? Oh, I didn't do it. No, you're not going to do it because this is OCD. So then we look at, now we introduce a non-fear association. I can drive. I won't pull my car off. Now we drive more and more and more. And the important part, we need to get rid of those safety behaviors, because our brain, if we're doing the safety behavior, thinks we're only safe because of the safety behavior, but that's not true. So maybe I put a stop sign visualize a stop sign while I'm driving in my head, so I don't do that. Or I sing a song. No, you can drive, not do the compulsion, and still not drive off. So that's called inhibitory learning model. We bring different models into ERP.
Wow, we're definitely going to have another interview on here because there's so much to this. And Angela says, I am ADHD, but I do definitely have some OCD traits, so it's confusing.
Mm-hmm. Yeah. Yeah.
Thank you, Angela. And hi, Hanumatha. Is there a biological basis for OCD?
Oh, well, the genetic factor, right?
Okay.
Yeah, this is what we definitely see. There's this connection with genetics, and so almost always. I mean, not always. I hate to use the always, but we do see
Yeah.
genetic.
Do you think you can, imagine you had parents who had OCD, do you think you're more likely to have it then, or not? It's just random. Like, would you copy parents? Did you learn the behavior?
Right. There's definitely influences in our environment. And so we're going to call that more influences.
Okay.
Yeah. We can learn behaviors and things like that. It can impact it. Yeah.
Yeah. No, thanks, Carrie. So basically the main thing to watch out for is if it's affecting your life.
Absolutely.
We all have these thoughts, don't we? Sometimes, oh, I've got to check this, or looking behind me. I remember when I used to always walk home at night, I would always check about 1,000 times more than any of my friends, which was a little bit over the top. But I mean,
you still walked home. Now, if you stop going out, now if that anxiety was so severe, then that's where it becomes a problem, right? So you still, we all have, compulsions and obsessions. It really, when it starts to negatively impact your life and it's lasting longer, and that's when, and then there are also antidepressants too. I just want to mention SSRIs, which are serotonin inhibitors, that the cool thing about what we do with the therapy is that we're changing our brain's neural pathways. We're creating new pathways. And when you take medication for OCD, what we see is when you stop the medication, the OCD symptoms come back, or, it doesn't eliminate them.
Yeah.
With therapy, you graduate, you become your own therapist, and it doesn't come back.
Yes. It takes longer, but there's no quick fixes. The quick fixes
or is it longer? Because you could be on antidepressants for the rest of your life, or you could go to therapy for 6 months, a year, and that's it.
Exactly. No, thank you so much, Carrie. I've learned so much, and we definitely have to have another conversation because I think there's just so much to learn about this topic. But is there anything else you want to tell us about OCD before we go? And also, how can people find you?
Oh, great. I want to say one thing about OCD is I adore working with individuals living with OCD. They are the most amazing, kind, strong individuals. So I just want to put that out there. They're just amazing. And how you can find me is iocounseling.com. So www.iocounseling.com. And yeah, I think, and
you can put that link on the post as well, so people can just click on it if you like.
Okay, great.
Yeah,
And then the other thing is, if you have some questions, I have great resources. So
amazing.
on my website, there are books, there's podcasts you can listen to learn more.
Amazing.
For OCD, anxiety, and perinatal is separate, but I'll go ahead.
Wow. Yeah, so if you put them all on the post, that will be absolutely amazing. People can just click on. And also you write amazing articles as well. So
I have articles as well that describe, so if you're just not sure and you're looking for I have lots of great resources, and reach out too. And if there's something, you can email me on the contact page, or ctorres at iocounseling.com.
Amazing. So please, thank you so much for coming. Oh, you have to put it, they won't get it from there. It needs to be on the post, on the actual post on LinkedIn. That's okay.
On LinkedIn. Okay, great. I will be there.
That's okay. Thank you so much, everybody, for joining. Thank you for your questions. It's been a pleasure. Please contact Carrie if you have any questions about OCD. Carrie is your expert. She has everything, resources and everything, and she's going to post them all in the.
Or I'll find out for you. I'll definitely, if I can help you with something, I'll find it out for you.
Thank you so much. And Angela said she's definitely going to check out your website, and she might get in contact with you. Thank you so much, everybody. Thank you so much, Carrie, and see you all next week.